So good evening to everybody. So welcome to the 48th edition of VIMS Anesthesia Alumni Academics. We have got two sessions lined up for today, two presentations, one by Dr. Bharat Paliwal, and he's going to speak on the airway ultrasound, and we have got a second presentation by Dr. Anita Chouhan. She's going to speak about preoperative considerations related to cardiac patients. And this is hosted by the Department of Anesthesiology and the Alumni Group of Anesthesia at VIMS Ballari, currently called as BMCRC. And we have the Ballari Anesthesia Society. So together, this program is being conducted every month for the last 48 months almost. Our president, Dr. Parimala, is also attending, and Dr. Josna, who is the secretary. Because Josna is not available and Dr. Parimala is suffering from pharyngitis. So I am trying to initiate the proceedings. And we are honored to have Dr. Srinivas, who is the current GC member of ISA National, with us. I request him to introduce the two speakers, starting with Dr. Bharat. Dr. Srinivas, please.
Yeah. Good evening, all. Again, welcome you to all to the 45th VIMS Anesthesia Academics, jointly conducted by Ballari Anesthesia Society and Department of Anesthesiology VIMS. And today we have got two important topics which are useful for both the practicing anesthesiologist and even the postgraduates. And we have got two eminent speakers. First lecture is by Dr. Bharat Paliwal. He's going to speak on airway ultrasound. He is currently Deputy Medical Superintendent and Additional Professor at AIMS Jodhpur. He has got a lot of honors and awards to his credit, and he has won nearly 8 awards with first prize during poster competition at New Zealand Pain Society Conference 2024 held at New Zealand, and again in SARC in 2017 held at Colombo, and he has also the prestigious ISA National Diligent Award in 2024. He has got 2 fellowships in pain management and certification in palliative care, and he is an instructor of BLS and ACLS and FCCS, and he is editorial member of and reviewer of JOACP and Indian Anesthetist Forum, and he has served as president and secretary of ISA Jodhpur, and he has got a lot of publications to his credit, nearly 63 national, 36 international, and he has authored 7 chapters in various books. This is about Dr. Bharat Paliwal. Welcome you. And next speaker is Dr. Anita Chouhan. She is presently working as assistant professor at AIMS Jodhpur. She has got, in addition to MD DNB, she has PDF in cardiac anesthesia, FCCE in critical care echocardiography, and fellow in ECMO. And her areas of interest are cardiac anesthesia and pediatric anesthesia. She is life member of ISA, IACTA, ICA, that is Indian College of Anesthesiologists, and RACC. So welcome you both the speakers, and I think we can start off with the first lecture. Thank you.
Thank you, sir.
Sir, you are not audible, sir.
Sorry. So you can start sharing, Dr. Bharat.
Okay. Thank you, Srinivaslu sir, and thank you, Bala Vaskar sir, to giving me an opportunity to interact with my parent institution, VIMS Ballari. I'm honored to be a part of it. I also thank the President and Secretary of the VIMS Ballari Anesthesia chapter. Uh, so today I will be discussing about ultrasound airway. Uh, Ultrasound has infiltrated into the anesthesia practice, and airway, which is the principal domain of anesthesiologist, how it can be spared from it. So, uh, going to today, my topic is based on what all we can do with the ultrasound in the airway. So coming to the basics, we have two probes that are commonly used. One is the linear probe and the curvilinear probe. As the basic goes, linear go is for the superficial structures and curvilinear is for the deeper structures. Uh, Most of the airway ultrasound is transcutaneous, although there are sublingual probe also available, but common use is through the transcutaneous mode. And we use curvilinear probe for the suprahyoid structures and linear probe for the infrahyoid structures. With respect to the position, it is the routine, regular sniffing position which we use for airway manipulation. So in supine position with head extension and neck flexion, we position the patient before the starting the scanning. The routine scan starts from the suprasternal notch and it extends up to the mentum or the floor of the mouth. There are two ways of scanning. One is the transverse scan and other is the midline or the parasagittal scan. Most of the scanning is in the transverse view. So we'll start with the transverse scan. Two another important things that need to be highlighted is one is the position, second is the probe, and third is what we are expecting on the ultrasound. As with ultrasound at other places, the structures may be hyperechoic, hypoechoic, echoic, isoechoic, or anechoic. So what are these by definitions? So for example, I have in the base of the slide, I have mentioned four images. So an hyperechoic is in common terms, it's more white than the surrounding structures. Bone is usually hyperechoic and it does not have any structures visible behind it. That is what we call as the acoustic shadowing. Then there are hypoechoic structures that are having less shininess than the surrounding structures. Isoechoic structures are difficult to make out because of they have the same echogenicity as the surrounding structures. Usually, ligaments comes in this category, and air does not allow transmission of ultrasound, so it appears black or anechoic. Although air is a what to say enemy of ultrasound, but with respect to the airway ultrasound, it's a friend because at the air mucosal interface we get a hyperechoic line and that help us delineate the structures with the airway. So our main focus will be on the air mucosal interface. Although there is no strict categorization, what is basic, what is advanced, but for understanding sake, I had divided into basic, the structures which can be directly identified and is of importance to us, and advanced includes measurement from those structures which are visible. So this is a brief anatomy of the airway. So we can see, is my cursor visible on the screen?
Yeah.
So as we move from the suprasternal area, so we have tracheal rings, then we have a thyroid isthmus and both the thyroid lobes, followed by cricoid cartilage and then the thyroid cartilage, and on the topmost we have a hyoid bone. So this is the usual anatomical structures. Above the hyoid, we have a suprahyoid structures that include the tongue or the genioglossus muscle. This is the basic anatomy, and we will be focusing on these structures in the ultrasound. How it appears, so we had placed the position in the with the neck extension, neck flexion and head extension. starting from the supraesternal area with the linear probe in hand, we are resting our hand on the patient's chest to have a firm stability on our probe movements. The very first structures which will be able to see will be the thyroid gland or the isthmus and the tracheal cartilage with the reverberating shadows. And as we go up, then we may be seeing other structures, but before that, what we can see on the left side is a fairly rounded structure that is collapsed. It is the esophagus. The best way to make out is this: ask the patient to swallow, and we can see the movements appearing in this area. So a short video follows where I had asked the patient to swallow. Keep a focus on this area. So as I swallow, we can see a movement over here. What is its importance? I will discuss later. So once we had, so this is the probe position, and these are the structures we can see: the air mucosal interface, the trachea, the thyroid isthmus with the thyroid lobes on the both side, and esophagus on the left. As we go cranially, then the rounded tracheal structures become more flat. It is now the cricoid cartilage. You can resemble it to the horseshoe structure. So we had moved from up from the tracheal rings to the cricoid cartilage, and this is the horseshoe structure which will be able to see. Further up we go, the horseshoe structures converts into a triangular structures, that is the tracheal cartilage. So we can see a V inverted U shape or a V shape structure. This is the thyroid cartilage, and along with it we will see in dynamic scan the movement of the vocal cords. So this is the inverted V-shaped structure. This is the thyroid cartilage, a boat-shaped structure with the adjoining vocal cords. So we have moved our probe from cricoid to the thyroid area. Beyond that, if we go even with the linear probe, we may be able to see the hyoid bone. So it is a boat-shaped structures or a bow-shaped structure. You can see it. So this is the greater corner or both the ends, and this is the body of the hyoid bone. So I had gone up. So this is the thyroid bone, and this is a bow-shaped structure. Another important structure which we can make out is the epiglottis. So for epiglottis, once we had made out the thyroid cartilage and the hyoid bone, we can gradually descend down and we can see a black area or this like a bat-like structure. This is the epiglottis. So I had come down from my probe and you can see that there is a bat-like structure. This is the epiglottis. So these are the important infrahyoid structures. These scans, what we had discussed, were made in the transverse view. If I make my probe in the sagittal or the midline plane, then I will be able to see the string of pearls appearance. So these black structures are the tracheal rings. A big hump at the beginning is the cricoid cartilage, and above that, connecting with the thyroid cartilage, is the cricothyroid membrane. So usually when we want to make out how is the cricothyroid membrane, then we follow the technique that is known as the TACA technique. TACA techniques, where T stands for thyroid cartilage, air is the air mucosal interface, C is the cricoid cartilage, and again we come down to see the air mucosal interface. So once we had seen this is our thyroid cartilage, below it when we see a boat-shaped structure, it's a cricoid cartilage. Sorry, this is the cricoid cartilage. In between, where you cannot see any cartilaginous shadow and white glistening structure, that is the cricothyroid membrane. So this is the cricothyroid membrane. So entire structures what we have discussed, I will try to show in a single scan. So I am starting from the supraesternal notch. You can make out this is the tracheal rings, the thyroid gland with the lobes and the isthmus. As I move cranially, it becomes a horseshoe shape. This is the cricoid cartilage. If I move even further, this is the cricothyroid membrane where the soft tissue has gone off. Then if I ascend further, that board shape, the horseshoe structure converts into a triangular structure. This is the thyroid cartilage with the moving vocal cords. You can appreciate the movement of the vocal cords. So this is a brief about the infrahyoid structures. So what are these applications? Once we had made out these structures, very first thing what we can confirm is the placement of the endotracheal tube. Once the tube is in the trachea, you can see this shimmering of the tracheal tube cuff. In case after intubation, you cannot, if you are not able to visualize it, then there may be a possibility that you have intubated the esophagus. In that case, we will have a double bubble sign where, similar to the tracheal tube, you will see on the left side a similar appearance of a rounded structure. So this can help us confirmation of the endotracheal intubation. There are other indirect ways also confirming endotracheal intubation. If you put the linear probe on the lung, you can able to see the pleural sliding. In the next slide, I will show how it appears. Although anybody can say that we can confirm endotracheal tube confirmation by pleural sliding with EtCO2. So what is the need of ultrasound in confirming the ET tube? So the one absolute indication what you may consider is during CPR. So during CPR, you give breaths intermittently, at least 2 breaths every 30 seconds, every cycle. So that point of time, you may not be able to see the pleural sliding. So if during CPR, you can easily confirm the endotracheal intubation through the ultrasound. So what is this pleural sliding? I will show you. So this is a short video where I put a linear probe on the chest and I can see the white shimmering line. This is the pleura. The video is little bit slow, probably because it was shot on a Mac and then it was transferred to this Windows. But you will see a rocket appearance over here. It's a easily identify once you put a linear probe on the chest. The other important aspect of ultrasound is that we can easily make out where is the cricothyroid membrane, where are the tracheal rings. So while doing a percutaneous tracheostomy in obese patients where palpation may not be sufficient to delineate the anatomy, we can use a probe in a midline or parasagittal plane to look for the tracheal rings. So these tracheal rings will appear as black dots. You can slightly move the probe up. Then you can be able to see the first hump, that is the cricoid cartilage. You further ascend the probe, then you will be able to see the cricothyroid membrane as the white glistening structures. And further up will be the thyroid cartilage. So we can easily count the tracheal rings 1, 2, 3, 4, and anywhere between the second to 4 tracheal rings we can mark and do the percutaneous tracheostomy. If you want to do a cricothyrotomy in a difficult airway before inducing the patient, you can mark the cricothyroid membrane, keep it, and in case of emergency, you may directly puncture at that site where you have previously marked. Another applications will be in giving airway blocks. So again, routinely thyroid hyoid bone can be palpated, but in obese patient, you can make out where is the hyoid bone, and the internal branch of the superior laryngeal nerve pierces the thyrohyoid membrane. So it will be difficult to delineate the nerve, but you can make out where is the greater horn of the hyoid bone, and you can directly deposit the local anesthetic below the greater horn of the hyoid, and you can anesthetize the superior laryngeal nerve. So these, to summarize, basic applications are endotracheal tube confirmation, In the esophagus, you can make out. If there is a rise tube there, you can make out. If accidental esophageal intubation is there, you can make out. You can make out vocal cord movements after a thyroid surgery. So you do not do a laryngoscopy to see the vocal cord mobility. By ultrasound also, you can just check for the vocal cord movement. Surgical procedure like cricothyroidotomy or percutaneous tracheostomy can be easily made out in obese patients where palpatory methods are insufficient, and you can carry out superior laryngeal nerve block. So coming on to the advanced applications, first is the anticipation of a difficult airway. So we have several parameters, but ultrasonographically also we can make out through use of suprahead parameters and infrahead parameters. As discussed earlier, suprahead structures are made out through the curvilinear probe. So how the sonoanatomy appears, it appears like the mentum or chin, it has the cranial end and hyoid bone at the caudal end, both appears black. Then you have a big tongue that can be easily made out, and the palate is the white glistening line. So between palate and tongue, you have air. So this is the black area, that is the space between the palate and tongue, and this entire area is your tongue. So this is how it appears with the curvilinear probe placed in a sagittal plane. Two parameters which we commonly measure in the suprahead is the hyoid bone related and those with the tongue related. So hyoid bone invisibility is established to be one of the signs of a difficult airway. So if you put a probe, you are not able to see a hyoid bone, then it is definitely a difficult airway. Another parameters which we routinely calculate are the hyomental distance in neutral position and in the extended position, and then we take out a ratio. In the further slide, I will show you that. And similarly, we do some of the tongue parameters. So this is the extended position. So we had placed a curvilinear probe, one placing at the mentum and other at the hyoid bone. We calculate the hyomental distance. So it is said that hyomental distance less than 5.29 centimeters. It is a marker of a difficult airway. Similarly, this is in the neutral position. You measure the same distances between the mentum and the hyoid, and subsequently you can take out the ratio. So ratio between an extended position and the neutral position, if it is less than 1.08, again it is a marker of a difficult intubation. In case of obese patient, when you use a ramp, the same ratio between neutral and extended position reduces to less than 1.12. So if the ratio is less than 1.12, again you anticipate a difficult airway. Coming on to the tongue, so you can calculate three parameters from the tongue. One is the tongue width and the tongue thickness. So as discussed earlier, so this entire area is the tongue. So distance between the two margins of the tongue you can make out as the tongue thickness and the tongue width. So if the tongue thickness is more than 6.1 centimeter, or you make out that there is no space between the palate and the tongue, then it is a difficult laryngoscopy. You don't have any much space for tongue manipulation. And if it is more than 6.1, it is 75% sensitivity and 72% specificity that you will encounter a difficult airway. Another thing is this height, what we called as the orocranial height. There is no much data what is the cutoff limit, but this oral cavity height ratio is frequently measured as one of the parameters for assessing the difficult airway. Tongue volume you can make out with use of measurement calipers, and large tongue can be again a difficult intubation parameters. Coming on to the infrahead parameters, now we consider with the neck soft tissue thickness. So there are three areas where it is commonly measured: at the hyoid level, at the preepiglottic level, and at the anterior commissure levels. And the another parameter that is commonly evaluated is the ratio of the pre-epiglottic distance skin thickness and distance between the epiglottis and the vocal cord. These are the two parameters in the infrahyoid area where calculation is routinely done. So I'm using a linear probe and placed at the hyoid bone. So this place I will measure the thickness. If the soft tissue thickness is around 1.28 centimeters, then it is 85% sensitive and 85% specific that I may encounter a difficult airway. So this is the hyoid bone, the bow-shaped structure, and this is the skin's anterior neck thickness that I have to measure. So this distance, if it is more than 1.28 centimeters, then I will have a difficult airway. Similarly, in the epiglottis, we had made out how to this batwing appearance will be there in the epiglottis. So again, in the epiglottis area, you have to see for skin thickness. It is if it is 1.78 centimeters, then you are 100% sensitive and 66% specific that you will encounter a difficult airway. Another third area where we commonly measure is at the level of anterior commissure. So skin thickness measured at the level of anterior commissure. If it is more than 1.1 centimeters, you have again 75% and 80% sensitive specific in predicting a difficult airway. Coming on to the ratio, this is the pre-epiglottic skin thickness, and this is the epiglottic and vocal cord distance. You take out this ratio. If it is ratio is more than 1.77, again it carries 82% sensitivity and specificity with respect to the difficult airway. So there is a online reference also available for the same. So what I had discussed was with respect to these parameters I had seen in these recorded data. A lay diagram of what we are actually measuring, the thickness at the level of hyoid bone, at the epiglottis level, at the vocal cord levels, at the supraesternal level. The same parameters as I had discussed, they are depicted in this tabular form. Another important concern with the airway is for the fasting status. So fasting status can be easily made out in gastric ultrasound, even in emergency or when patient is not giving history with the use of the curvilinear probe. So the gastric ultrasound is both qualitative and quantitatively it is helpful. For the qualitative way, we do it in supine position as well as in the right lateral decubitus position. In the right lateral decubitus position, what we see is the left lobe of the liver descending. Here we see an aorta and the emerging superior mesenteric artery, and posteriorly there is pancreas. So antrum is occupied, lies between the posterior lobe of liver and the pancreas. We can make out this cross-sectional area. If the cross-sectional area we have a formula known as the for the residual volume. The formula goes by that 27 plus 14.6 into cross-sectional area in the right lateral decubitus position minus 1.2 into age. So if this calculation comes out that gastric residual volume is more than 1.5 ml per kg, then patient has a high risk of aspiration. So this is what is known as the quantitative. If you don't want to go for quantitative, we have a qualitative parameters that can be taken in both supine and right lateral decubitus position. In grade 0, if a patient is fasting, then your antrum will not be visualized. The entire thing will be collapsed, and what we call it as a bullseye appearance. If the patient have liquid, then it will be either grade 1 or 2. If the liquid is seen in only supine position, then it is grade 1. If it is seen in both supine and lateral, then it is grade 2. Both grade 2 and 3, they are high risk of aspiration. Grade 3 is presence of solid material. So just I will show a brief scan how it appears. So this is you can see the pulsatile aorta and superior mesenteric artery emerging from it. Color Doppler will be much helpful in making out this. And this is the entire antrum and pancreas interposed between pancreas and the left lobe of the liver. Another important thing is before extubation, we want to make out whether the extubation will be successful or not. So what we can do is we can deflate the cuff and look for any air column width. So this just in a short video. So here we have deflated the cuff, so we can see a thin margin of air column. So if it is more than 16 mm or 16 mm, then you have a pretty fair chance that patient will not develop post extubation stridor. So, the last advantage is that we can calculate the size of the tube before intubation, especially in pediatric age group where uncuffed tube size is used. So if we measure the subglottic transverse diameter at the cricoid level, so the diameter will help out. Suppose in this case it is 8.8 mm. Then the maximum size of the tube that we can pass through the trachea should be having an external diameter of less than 8.8 mm. In adults, routinely requiring a double lumen tube for some procedures, they undergo a CT scan. If you want to make out what will be the size of the double lumen tube, then based on the outer tracheal diameter, which we measure using ultrasound, the formula is that left main stem bronchus size divided by the outer tracheal diameter, the ratio is 0.68 mm. So we want to say how much is the size of left mainstem bronchus, then it will be 0.68 mm into the outer tracheal diameter measured through the ultrasound. This way we can calculate which size of the double lumen tube or left-sided double lumen tube we can use. The same can be used to make out the size of the tracheostomy tube. So to summarize, the advanced applications are prediction of difficult airway, prediction of the fasting status, making out whether post-extubation stridor will be there, and making out of the tube size in pediatric age group and DLT and tracheostomy size in the adult age group. So these are my references. Thank you.
Thank you very much, Dr. Bharat. Please stop the screen sharing and thank you. And of course, I somehow forgot to introduce you as an alumni of Ballari Medical College. So,
Yes, sir, I am grateful to be your student, sir.
thank you.
Sir has taught me in my MBBS days, and I was mesmerized by the way he used to teach interns as well.
Thank you. Thank you. And we are happy that you took up anesthesia also subsequently. And
so you have an important role to play in my choice because I was fascinated during internship with the ventilators, the ICU care we used to give there, and the teaching. So that helped me to choose my subjects.
Thank you. Thank you very much. We'll take questions if whatever they are there towards the end, Dr. Bharat. So we'll have Dr. Anita. She'll be speaking about the preoperative assessment of cardiac patients. Dr. Anita, you can please, Chouhan, please go ahead and share your presentation also.
Yes, sir.
Thank you.
Is it visible, sir?
Yes.
Yeah, we can.
Good evening, everyone, and thank you, ISA Ballari team, Bala sir and the Srinivas sir for giving me this opportunity. So our topic of discussion is preoperative evaluation and risk assessment in cardiac surgery. So why this is important topic? Because as we know that we have learned about the multiple articles that preoperative evaluation in the cardiac patients undergoing non-cardiac surgery. So there are a lot of literature which is about the non-cardiac surgery, but very few literature present in the cardiac surgery patients. So that's why this topic of discussion is important for the MD students. And there is two limitation of this topic. First limitation, that there is a lot of overlap between the cardiac surgery patients and the non-cardiac surgery patients. So this is very difficult to segregate the risk assessment tool in the cardiac surgery patients and the non-cardiac surgery patients. But still, I try to separate them and mention that which is for non-cardiac surgery, which is for cardiac surgery. And another limitation of this presentation is that we have a lot of literature in the adult patients, so very few in pediatric patient. Although the pediatric patients have the more mortality, but still we have very few risk assessment tool and very few preoperative evaluation strategies in pediatric patient. So whatever we have, I mentioned in this PPT. So starting with the PPT, it's not moving. Okay, so goals of preoperative evaluation to risk stratification, because we have to identify which patient is high risk patient and which patient is the low risk patient for cardiac surgery, and optimization of medical conditions such as diabetes, COPD, hypothyroidism. All these patients should be optimized before the surgery, and the assessment of cardiac function is the most important criteria for the cardiac surgery patients, and the preoperative management strategy for the patients undergoing for the cardiac surgery. So preoperative assessment includes the demographics. We have three most important things. One is demographic, second is the functional status, and the third is the risk assessment tool. So first is demographic. What demographic includes? It includes age. So we have multiple literature that if the patient is more than 65 years of age, will have the higher mortality. Or we can say the patients who have elderly, that is more than 80 years old, will have the higher mortality than the patients who are at the age of 60 years. And the sex. And it is documented that the female patients are more prone to the high risk complications or the perioperative mortality in the cardiac surgeries. And the body size also included, because the pediatric patients and the female patients are more prone for the perioperative mortality because of the reduced body size. And the previous MI, it is important for the non-cardiac surgery. Basically, if the previous MI surgery is there, or the recent angina history is present in patients, or the previous cardiac surgery is important in the patients, because the redo cardiac surgery, that is revised cardiac surgery, is further more complicated and it is associated with the higher mortality. And the combined procedures, like the patients going solely for the CABG or the patients going for the CABG plus valvular. So CABG plus valvular patients will have the higher mortality. So we should know about the demographics and the procedure of the patients. Then detailed medical history, as all the patients going through the history evaluation. So we should go for the thoroughly history of the cardiovascular system, like the symptoms of the cardinal symptoms of the cardiac disease, like the angina, dyspnea, and the syncope. So history of MI, heart failure, arrhythmia, valvular heart disease, or the previous cardiac interventions like PCI, valvular replacement, or the balloon valvulotomy. We should ask all the history things. So this is the Canadian classification of the angina. When we are going through the cardinal symptoms, we are asking for the angina, and we assess the grade of the angina, that grade 1, 2, or 3, or the 4. 3 and 4 are the marked limitation of the ordinary physical activity which causes the angina, and fourth is inability to carry out any physical activity which will cause the angina. Third and fourth category will be the high risk patients, or will have the higher mortality. And the second cardinal symptom is the dyspnea graded as the NYHA class. As we know, all the cardiac patient, mostly the cardiac patient, will come with the NYHA grade 3 and the 4. 3 says the marked limitation of the physical activity, and 4th is the unable to carry any physical activity. So NYHA grade 3 and 4 will have again the high perioperative mortality. Then risk categorization of the surgery. After assessing the patient's history, we categorize the patient into the minimum risk, intermediate risk, or the high risk. As the patient is hemodynamically stable, or the patient is posted for the elective surgery, will come into the minimal risk. And the patient who have the hemodynamic stability but posted for the urgent surgery, or the patients on the antiplatelet therapy or the LMWH, will comes into intermediate risk patients. Or the patients who are having the acute MI, ischemia, or these patients are hemodynamically unstable, emergency revascularization indicated, or emergency CABG indicated, these patients comes in the high risk category. So this is like the example of MI patient. We evaluated the patient, comprehensive evaluation needed, and then we categorize the patient into the low risk, intermediate risk, or the high risk patient. So low risk patients who are posted electively for the CABG, while the intermediate risk patient who are posted for the urgent surgical vascularization, or the delayed surgical vascularization, or the longer delayed 5 to 7, or patients on the antiplatelet therapy, they will come in under the intermediate risk. For the high risk patients who are having the refractory angina, cardiogenic shock, or very severe MR, or rupture of free wall, will posted for the emergency surgery, will come under the high risk patients. So very few risk factors which is particularly specific for the cardiac surgery, like the ejection fraction. Many times we have heard that our consultant used to ask what is the ejection fraction of the patient, because this is the very important criteria to document that perioperative mortality, how much will be the perioperative mortality. And then unstable angina or the recent MI history will again the associated with higher perioperative mortality. And the heart failure symptoms like LV failure symptoms or the right heart failure symptoms, congestive heart failure, all these symptoms are associated with the high risk mortality. And the age more than 65 years associated with the perioperative high mortality. And then severe obesity. This is like very much literature said that severe obesity is associated with the poor outcome in the cardiac surgery patients and the emergency surgery and reoperation. So LV failures patients can present with the exertional dyspnea, orthopnea, PND, fatigue, pulmonary edema, cyanosis, basal crepitation, gallop rhythm. So we should ask the history of particular patients. And RV failure features like pedal edema, ascites, abdominal discomfort, JVP, hepatojugular reflex. These are the symptoms of the patient with the RV failure or right heart failure. Or we should ask about the diastolic and the systolic heart failure, that can be the impaired LV relaxation or increased stiffness or the ventricular arrhythmias. And the acute coronary syndrome in cardiac surgery can be seen as the ST elevation or the ST depression. We can say the NSTMI or the STMI. So it has documented that the patients who are having recent non-ST elevation have the higher mortality rather than the STMI. And this is like example, if the patient is having the ACS and having the non-STMI, will be the having the high mortality. And if we are delaying that patient or we are giving time to recover for 3 to 7 days and we are delaying the CABG, then it will be beneficial for these patients. While the patients who had the RV MI or the having the pre-wall rupture, RVMI, and we can give them time to recover him. And if they are hemodynamically stable, we can give the time to recover their myocardial segments, so they will be beneficial for delaying the surgery. And another is the non-cardiac risk factor. Non-cardiac risk factor like hypertension, COPD, diabetes, OSA, and hypothyroidism. These are the very common sedentary lifestyle diseases which is common in cardiac surgery patients. So most commonly the diabetes. Diabetes is the very common. So there are few trials which says in the diabetic patient which is the most beneficial, like CABG, PCI, or the medical therapy. So there is a big trial, cardia trial, that is coronary artery revascularization in diabetes, which was comparing the CABG versus the PCI. So it was concluded that CABG shows the lower mortality in the diabetes patient. Then again, the second trial is the BURY 2D trial, that is the bypass angioplasty revascularization investigations into type 2 diabetes. It was the difference in between the medical therapy and the PCI. So in this, there were no significant difference in the outcome of the patients. And another trial is the freedom trial, that is the future revascularization evaluation in patients with diabetes, which was the 5 years mortality. So it was suggested that versus CABG versus PCI, that 5 years mortality is less in the patients undergoing CABG, but the high stroke rate were in the CABG patients compared to the PCI patients. And renal dysfunction is very common in the patients posted for cardiac surgery. So if patients already having the renal dysfunctions like increased creatinine level, or the patients having the dialysis, these are the high surgical risk mortality patients. And the patients who are undergoing cardiac surgery and the post AKI is very common in these surgery patient, cardiac surgery patients. So if GFR is less than 30 ml per minute, they will have the higher mortality, that is suggested around 10% mortality in compared to the normal renal function. So prevention can be done if we are predicting the AKI in few patients. What we can do, that if the patients going through the angiography and contrast agents, then we can delay the surgery for 24 hours for the minimizing the AKI incidence in the post-operative period. And then functional status is most important assessment, and we can say which is the one single parameter for any patient to evaluate post-operative complications or the perioperative mortality. It is functional statement, whether the patient's going through the cardiac surgery or the non-cardiac surgery. So functional status is the very important features. So we can assess the functional status by the MET scoring or the Duke's activity scoring or the 6-minute walk test. So METS is the metabolic equivalent of task. So 1 MET equal to the resting oxygen consumption of a 40-year-old patient or the 70 kg patients. So 1 MET equals to the 7 calories per 5 minutes. So we know that the patients having METs less than 4 will be having the poor outcome, while the patients having the more than 10 METs will have the excellent outcome. So in between there, 4 to 6 METs will have the moderate outcome, and the 7 to 10 will have the good outcome of the perioperative mortality. And another scoring is the DASI scoring or DASI questionnaire, that is Duke's Activity Status Index. So it is the questionnaire in which we ask few questions like, are you able to take care of yourself, or you can are you able to walk indoors? And these are the questions we ask to the patient, and there is number assigned to each and every question. So this is ranges from 0 to 58. 0 is the minimum number, which is equal to 2.7 minutes, and the maximum is 58, which is approximate 9.89 METs, which is good or excellent outcome. So if patients having the less than 34 scoring in the this scoring, DASI scoring, they will have the increased risk of MI, moderate to severe complication, and new disability following the non-cardiac surgery. So it is also for the non-cardiac surgery. And another test, 6-minute walk test. We have done this test in the COVID time, 6-minute test. 6-minute walk test is the test we ask the patient to travel for the 6 minutes on his pace of walking. So there is documentation, particularly if the patient is able to walk more than 563 meter. It is not like 562 or 564. It is very fixed criteria, that is more than 563 meter. That means no further testing required. That patient is fit, like he is able to walk in that speed. That means the patient will have the good outcome of the surgery. While the patients who are having less than 427 meter, then there will be need for other evaluation like stress echo and other parameters to assess. And if the patient is able to travel around 427 to 563 meter, that is we have to evaluate other parameters to say that patients have the poor outcome for the surgery. Another is the physical examination. So physical examination of the system cardiovascular and respiratory is important for such patients. So for cardiovascular examination, we auscultate for the murmur, gallop rhythm, rubs, or the indicating valvular or myocardial pathology, and assessment of peripheral pulses and the sign of heart failure. And respiratory examination for pulmonary congestion or underlying lung disease, or the patient in congestive heart failure, we assess the cardiovascular system examination fully. And the general examination for the cyanosis, clubbing, pallor, and the BMI. Assessment of nutritional status and BMI is important to know about the further procedure like the cannulation size and the valve size. All these important to know with the BMI or the nutritional status. And this is the modified Allen's test. We in cardiac surgery usually require the frequent ABGs. We place the radial cannulation, so we should know about the collateral supply in the hand. So how we do this modified ulnar test, that we locate the ulnar and radial artery, and we ask the patient to make a fist for 30 seconds, and we obstruct the flow and press down the ulnar artery with the 2 fingers. At the same time, we press down the radial artery, and then we tell the patient to unclench, and then we assess the blanching of the palm. Negative modified Allen's test, that means when we release the pressure over the ulnar artery, hand flushes within a 5 to 15 seconds. That is the negative modified Allen test. That means the patient is having good collateral supply. While the patients having positive Allen's test, that means that uh, while releasing the ulnar artery, there is blanching of the hand. There is no flushing in the hand. That means there is poor collateral supply. So sometimes we need to harvest the radial artery for the CABG and cannulation, radial cannulation for cardiac surgery patients. So we should evaluate the collateral supply in the hand, as well as so we should see the peripheral pulses. Then investigations. So relevant investigations like CBC to rule out the anemia, because the anemia is poorly tolerated in the cardiac surgery patients, and RFT, electrolytes to evaluate the preoperative AKI or the postoperative prediction of AKI, LFT, and the coagulation profile, and cardiac specific biomarker like troponins and the BNP, anti-proBNP for the heart failure risk. It is like pro BNP is less than 125 picogram per ml is normal in adult patients, while trop I, trop T or high sensitivity cardiac troponin 0.04 nanogram per ml are the normal value. And it is been studied that elevated BNP level are the associated with high mortality, especially in the cardiac surgery and also in the TAVI patients going through the TAVI surgery. And blood grouping and cross matching is important for the surgery. And advanced imaging like the ECG. We can see the arrhythmias in the ECG or the hypertrophy of the chambers. And why echo is important, we'll discuss in the later slide. And chest X-ray, we can see the chest X-ray, and we can see this patients having the COPD or what is the chambers diameter, like cardiomegaly or the left aortic arch or the right aortic arch, or the patients having the aortic dilatation, we can see in the chest X-ray. And angiography is important for the patients going through the CABG, so we can see which vessel is involved, with how much stenosis in the vessel. And CT and MRI is important for the particularly pediatric patient where the echo window is not much good, so we can go through the CT or MRI. Carotid Doppler. Why carotid Doppler is important? Because many times the patients, elderly patients, having the carotid plaques or the carotid stenosis. So in the post-op period, many patients develop this adverse cerebrovascular incidents like the stroke or post-op cognition defect, and this is always blamed that because of anesthesia it has happened. But that's why we are assessing the carotid Doppler, so we can at least pre-operatively make out that this patient will have the adverse cerebrovascular event in the post-op period. So we should see the carotid Doppler also. And in the echo, what we are seeing, the LV size, LV wall thickness, LA size, and if the patients are having aortic regurgitation, we see the end systolic diameter. If it is more than 5 centimeter, it is associated with poor outcome. And if it patient of MR and more than 4 centimeter end diastolic diameter, it is associated with poor outcome. And we can see in echo S prime velocity, which is tissue Doppler velocity. It is suggested that if it is less than 3 centimeter per second, it is suggestive of cardiac death within 2 years. So in echo, we can see what patient's outcome will be. And strain for the patients who have the uh, who are going through the CABG. So minus 16 to minus 19 is the normal value. If the positive strain, that means the LV contractility is not good or the more vessels are involved. And we should see the PA pressures and the gradient across the valve in the valvular pathologies. So that's why the echo is important to know. And patients who are already having on the multiple antiplatelets, anticoagulant, and fibrinolytic agents. So those patients who are having on the aspirin, clopidogrel, and such patients, if this is not feasible to stop clopidogrel, so bleeding risk will high. So what we can do, we can counteract this effect with the antiplatelet. So counteract the effect of antiplatelet agent by administering the platelet administration, platelet infusion. And the patients on anticoagulants such as warfarin, if the urgent surgeries, emergency surgeries, we cannot it is not feasible to stop the warfarin, that what we can do, we can transfuse the PCC, that is prothrombin complex concentrator, or the vitamin K. Over the FFP, it is preferred PCC and vitamin K. And the patients on the fibrinolytic agents, those patients who are gone through the streptokinase therapy and fibrinolytic agents, we can counteract these effect with the cryoprecipitate plasma or fibrinogen concentrator. So we should know about what drugs patients is taking right now for the surgery, before the surgery. So these are the drugs like alpha blocker, alpha agonist, antiarrhythmic agents, beta blockers, calcium channel blockers, statins, and nitric oxide and vasodilator. These are the drugs which we can allow the patients to take 1 day prior the surgery, because these are the not contraindicated. These are the helpful in patients to good outcome of the surgery. And these are the drugs which should discontinue on the day of surgery, like S inhibitors, ARB inhibitors, diuretics, and the direct renin inhibitor. This is documented in CABG that ACE inhibitor and ARBs, if the patient takes on the day of surgery, it associated with poor outcome. This is the performer of our institute for the cardiac patient. So in this performa, we can see we have a column for demographics and risk factors or the comorbidities. And here is the column for the medication, that patient was on the diuretics or patient on the enalapril. And this is the column for the brief history, that what was the grade of NYHA, what was the grade of, this was the patient of congenital surgery. So this is the column for general physical examination, airway examination, and this is the column for the Allen's test or the peripheral pulses. So we should see on in the both limbs, right limb and the left limb. And this is the column for the systemic examination and the column for the investigations, all the routine investigation. And this is the column for ECG and the echo. We can see here we can write the detailed echo. And this is the column for angiography details, that left main coronary stenosis, or what is the ejection fraction, what is the uh, um, what is the ejection fraction, what is the mode of the angiography, and chest x-ray, PFT, and carotid Doppler, and the USG. And this is the instruction column, what drugs should be taken on the day of surgery or what should be stopped. Then third parameter is the risk stratification. We have gone through the two parameters. One is the demographics, second is the functional status, and third is the risk stratification, that is scoring system. So we know that we have multiple overlapping risk assessment tool, that is for non-cardiac surgery and cardiac surgery. So Goldman Cardiac Risk Index, this is been using from the ages. Nowadays we are not using it frequently, but in literature it was given, Goldman Cardiac Risk Index. So we are asking, we are looking for these symptoms, like patient is having, whether the patient is having third heart sound, recent MI, or the age more than 70 years. According to that, we are predicting the cardiac complication rate. Like if the patient's having 0 to 5 points, that means 1% cardiac complication. If the patient is more than 26 points, patient will have 78% of cardiac complication. But nowadays what we are using is the RCRI, that is Lee's revised cardiac risk index. It is also for the non-cardiac surgery. So in this, there are 6 points we use to ask the patient going through the major surgery: history of IHD, history of congestive heart failure, history of cerebrovascular disease, diabetes, or create. According to that, we are predicting the post-operative adverse cardiac event. If the patient is having more than 3 of them, the patient will have 11% of post adverse cardiac event risk. And then Euroscore. So Euroscore is the European system for cardiac operative risk evaluation. This is for the cardiac surgery patients. So this predicted the 30 days mortality in cardiac surgery patients, and it identified the high risk patient, but limitation that it underestimate risk patients in patients going through the complex cardiac surgery, or it overestimates in the patients who are young. So there are few drawbacks of this scoring. Euroscore 1 and Euroscore 2. In 2011 around, Euroscore 2, Euroscore 1 was revised up to Euroscore 2. So Euroscore has the patient related risk factor, cardiac related risk factor, or the operation related risk factor. So patient related risk factors include the demographics, like the age, gender, or the patient having COPD, extracardiac cardiopathy, or the create more than 2, neurological dysfunction, previous cardiac surgery, or the active endocarditis, or the critical pre-op status, all assigned as the point 1, 2, or 3. Or the cardiac related risk factors like unstable angina, points 2, LV dysfunction 1, recent MI 2, and pulmonary arterial hypertension 2. And operation related or surgery related risk factor like the emergency 2, other than isolated CABG 2, post infarct septal rupture 4, and surgery on thoracic aorta 3. So we can see what all the parameters we have discussed, that these are the parameter which is related to the poor outcome. So all these included in the Euroscore. So Euroscore predicts the 30 days mortality, and it is like if the patient is having 0 to 2, that means 1.3% mortality. If the patient's scoring is 3 to 5, that 2.9% mortality. If patient is having more than 6, that is 10.9 to 11.5% of mortality. Then it is the performance of Euroscore 2 in CABG patients, which is saying that Euroscore 2 had good discriminative accuracy independently of sex, age, but markedly overestimate mortality risk, especially in younger patients. This was the limitation of that score. And accuracy and calibration were better in high risk patients than in the low risk and intermediate risk patients. So it is very good for identifying high risk patients. And this is the study done in the Indian patients. So it was saying that Euroscore 2 in Indian cardiac patients undergoing cardiac surgery is lesser than the European patients. So incidence of mortality is higher in the patient with high Euroscore. So as per study, patients with high Euroscore tends to stay longer in the ICU. So in Indian patients also we are using Euroscore 2. Then the STS risk calculator, that is the surgical tool. Basically, Society of Thoracic Surgeons made this scoring. We have an online calculator for STS risk calculator, risk stratification. So in this we have multiple data entry that predicts the mortality and surgical risk basically. So we can predict the risk of mortality, morbidity by demographics, clinical variable like lung function, kidney function, CABG, arrhythmias, frailty, dementia, liver disease. And this scoring was not designed with the for the TAVI patient, but there is the study which says it can be used for the TAVI patients also. So it predicts the risk of surgical mortality of 4 to 8%, which is considered as the intermediate risk, or the patients having 8%, that is considered as the high risk patients. So this was the study which was saying that it can be used, STS scoring can be used in the TAVI patient. So conclusion was the STS score outperformed the logistic Euro score in predicting adverse outcome following the TAVI surgery. That is the transaortic valve implantation. Another scoring is the cardiac surgery score, which includes the respiratory analysis, renal system analysis, liver functions, cardiovascular, which includes the lactic acid, IABP, ventricular assist devices, and the coagulation and the central nervous system status. So it includes the 6.4 or more could signify mortality and post-op morbidity. Then the Prasonet additive risk index. Previously, Prasonet was very popular scaling to for perioperative mortality because it is having all the parameters like demographics plus hypertension, comorbidities like hypertension, diabetes, obesity, and dialysis dependency, or the cardiac functions like LV function, good, moderate, or poor, LV aneurysm, redo surgery, preoperative IABP, mitral valve surgery, or the aortic valve surgery. So all these parameters included in the Prasonet risk. So according to the Prasonet, we are categorizing the patients into the normal, fair, poor, or high risk patients. So in the high risk patients, the patients getting the scoring of 15 to 19 will have the mortality of 17%. So it is also a good scoring to predict the mortality. Then NSQIP scoring, that is the National Surgical Quality Improvement Program. This is also meant for the non-cardiac surgery. This was including the 21 variables. So it is available online. We can see in this table that procedure, age, risk, functional status, and wound class, ascites prior to the surgery, diabetes, hypertension, all these variables involved in this. Outcome assessed through the NSQIP is the MI or the cardiac arrest. So MI defined as the ST elevation, new Q waves, new LBB, and drop more than 3 times. So it is good because it is disease specific, but it is not good for the CAD, aortic stenosis. These are not the variable for this NSQIP. It is also used in the non-cardiac surgery. Then the surgical outcome risk tool, SORT tool. It is also available online, and we can see all the parameters like ASA class, surgical severity, or any comorbidities and demographics. We include all these things in this tool also. Then American University of Barrett, AUB classification. This is also for the non-cardiac surgery. It also involves the heart disease, history of heart disease, symptoms of heart disease, age or anemia, or surgery, which is emergency or the vascular surgery, and classified as the low risk, intermediate risk, and high risk score according to the scores. If they score more than 3, it is high risk patients. And this is the another score, PEACH score, which is also for the cardiac surgery. One study was done, and it was suggesting that if the patient's having the 0 point, that means the low cardiac risk, low in hospital mortality, and if the patient's having more than 3 point, that means the high in hospital mortality, which is around 17.2%, and involving the NYHS status, urgent surgery, endocarditis, and the previous cardiac surgery. Then we assess the Apart from the cardiac risk tool, we assess the pulmonary functions also. Why pulmonary functions? Because it is said that post-op pulmonary complications are very common in the patients going through the sternotomy. So we assess the PFT prior to the patient posted, and we have risk score tool, that is ARISCAT scoring, to predict the post-operative pulmonary complications. So ARISCAT using the parameters like age and respiratory infection, SpO2, pre-op SpO2, or the upper abdominal incision, because sternotomy is the upper abdominal incision, intrathoracic incision, surgery duration, and the emergency procedure. According to that, post pulmonary complications sign, like if the patient is getting 45 points, that is the high risk patients. So post op pulmonary complication would be the 42%. Then another kind of risk, like the thromboembolic events, are common in the cardiac surgery patients. So CHAD scoring is useful to predict these thromboembolic event, the atrial fibrillation patient. And the bleeding scoring risk, like Hess bleed risk, which predicts the balance the anticoagulation and the bleeding risk in cardiac patients. So CHAD scoring tells about the congestive heart failure, hypertension, age more than 75, diabetes, stroke, vascular disease, age, and the female category. And then Hess bleed score include the hypertension, abnormal renal function, stroke, bleeding, and labile AMR, elderly, or the patients on drugs or alcohol. So it predicts the bleeding risk. Then the frailty index. So we have said that if the patient is having more than 65 years of age, will have the poor outcome. But it is also said that it is not the chronological age, it is physiological age. So we should assess the frailty for the patients who are undergoing through the cardiac surgery. So we can assess the frailty by multiple scoring, like Fried Frailty Index or the Clinical Frailty Index, that how much the patient is working, like patient is very fit, or the well, or the managing well, vulnerable patients, or the mildly frail patients, or the moderately frail patients, or the severely frail patients, or the very severely frail patients. So moderately frail, severely frail, and the very severely frail patient will have the poor outcome of the surgery. And the Rockwood Clinical Frailty Scale and Edmonton Frail Scale. So these all frailty scorings are available online. We can use any scoring to predict the post-operative mortality and morbidity in cardiac surgery patients. And now this is the RACHS score. This is score for the congenital heart surgery. As I said that the limitation of this topic was the pediatric scoring. So we do not have particular much pediatric scoring. We have this RACHS scoring, which divides nearly all surgical procedure for CHD into the 6 categories of increasing operative risk mortality. So we are concluding that patient's operation type is the ASD repair, or the VSD repair, or the TOF repair, or the CAVC, or the truncus repair. According to that, we assign the RACH scoring number. More the scoring will have the more mortality. And this is the adult CHD scoring, which includes the 0, 1, or 2 scoring, which was telling CHD diagnosis, intervention, ventricular obstruction, PVR, hematocrit, arrhythmias. So higher the number, higher will be the mortality. So for CHD and the pediatric patient, we do not have much data. Then another important thing to know about the cardiac status, that severity of disease. Like if the patient is having valvular lesion, we should know about the moderate to severe lesions, because these are the if the patient is having the severe lesion, then we should know that severity depends. If the patient is having severe lesion, that means the outcome will be the poor rather than the moderate lesion. And number of vessels involved, if the patient posted for CABG, we should see the whether the myocardium has damaged or the preserved. And it is documented that proximal left circumflex artery stenosis is the independent predictor of mortality. So we should see which vessel is involved, LAD, circumflex, or the RCA. And the congestive heart failure, again, it is associated with the poor outcome and the high perioperative mortality. And then LV failure, and the LV aortic stenosis, which is low flow, low gradient, it is mostly associated with high mortality. And the arrhythmias, mostly atrial fibrillation is common, and the pulmonary hypertension patients. Then independent predictor of mortality and mortality, that use of IABP for separation for CPB, that means the patient will have the high mortality and morbidity. And the CPB time, that pump time, it is more than 160 minutes. It is documented that these patients will have the high mortality and morbidity rather than the patients having low pump time. And again the procedures like CABG versus the CABG plus LV aneurysm. So CABG plus LV aneurysm will have the higher mortality, or the patient posted for AVR versus the Bantal procedure. So Bantal procedure will have the higher mortality. So CABG versus CABG valve, the CABG valve will have the higher mortality. So in all the risk assessment tool, we have seen that a type of surgery is very important, which surgery surgery also contains the multiple individual scoring. So concluding this PPT, that assessment of cardiovascular risk should be a part of preoperative evaluation. This should be done by us anesthesiologists to measure the risk and to minimize the risk and to optimize the patient, and improved outcome is expected after evaluating the patients all the risk stratifications. Thank you.
Yeah. Thank you very much, Dr. Anita.
Thank you, sir.
It's a very painstaking effort because you've got so many assessment tools and scoring systems.
Yes, sir.
Made it is difficult for it to compile. And advantage of this presentation is we are going to put it up in the YouTube, and the PGs and the practitioners can go there and they can also get the details, the updated details. I think we can have some question answer session now. There was one question already which has been answered by Dr. Bharat.
Already answered.
Yeah. So Dr. Parimala, she is asked about, can we make our endobronchial intubation? Can we make out endobronchial intubation by airway ultrasound? Okay. So Dr. Bharat, you can just
Yeah. So,
convey.
nice question. We can easily make out. So most of the time it's the right bronchial intubation. That's why I replied for the right bronchial. In case your tube is in the right bronchus, then only the right lung will be ventilated. So the pleural sliding will be visible only on the right side. On the left side, you will not be able to see the pleural sliding. What you will see there will be the lung pulse. So as I had shown you in my video that you place a linear probe on the chest, and then you can see the pleural shimmering line movement that will be absent on the left side. Similarly, if by chance the tube enters into the left bronchus, then the same findings will reverse. That is, you will see a lung sliding on the left side, but absence of lung sliding on the right side. And there you will see a lung pulse. So lung pulse is nothing but it is the cardiac oscillations that are visible once you place a probe.
Okay. Thank you. Dr. Parimala would listen because I told you she has got some pharyngitis also.
Yes.
Of explanation. And now we have the PGs also. In fact, their exams are due next 3-4 days. Can you just convey in terms of the validated assessment tools, which could be the best ultrasound-based valid tool for predicting difficult laryngoscopy, number one, and number two, probably predicting difficult intubation per se.
Sir, with respect to ultrasound assessment tools, the literature is not that much. So whatever I had shared with you was the frequently followed, because even in that data, different studies have quoted different dimensions. So some had said 1.12 centimeters, suppose, for anterior nape thickness in the hyoid, or hyomental distance less than 5.29 centimeters as a predictor of difficult laryngoscopy. But the most common ones which we can follow are that if you find absence of parapharyngeal space, that is a difference. There is no black area between the tongue and the palate. So that is a difficult predictor of your laryngoscopy. Second, hyoid bone. Absence of visibility of hyoid bone on the ultrasound. Sure, it's a strong predictor of having a difficult airway. So these two things are there. And the other commonly followed is the tongue thickness. So if tongue thickness is more than 6.1 centimeters, again, you will find a difficult airway. another two more parameters, that is the ratio of hyomental distance in extended position and those in the neutral position. And with respect to anterior neck soft tissue thickness, the ratio of pre-epiglottic to the ratio of pre-epiglottic and vocal cord. The epiglottics and the vocal cord. These 4 or 5 are the most commonly one followed.
Yeah.
Actually, in this latest issue of IJ, there is an article like using 5-point ultrasound, that is trachea and bilateral pleural movement and diaphragmatic excursion, to detect, to confirm that in regular endotracheal intubation or to detect endobronchial intubation in pediatric patients. They have compared it with the regular ultrasound, clinical detection, and the ultras. And I think the ETCO2 waveform. They have found a comparable time for three different things like clinical, ultrasound, and carbon dioxide waveform. 5-point 5-point ultrasound for pediatric endotracheal intubation or to detect endobronchial intubation. Actually, it was a good article to go through that.
So distal benefits keep on going. And anything about the laryngeal edema per se? There have been some case reports and prolonged surgeries, and where we think about risk of laryngeal edema. Of course,
Sir,
we
I
put
had,
elective. Yes.
so what I could find was the absence of any air column once you deflate the pilot balloon.
Yeah.
So on ventilator, we see a leak as on the monitor that delivered tidal volume and the exhaled tidal volume, there is a discrepancy.
Yeah.
In case you have a laryngeal edema, we do not find that they, even after cuff deflation, the delivered tidal volume and exhaled tidal volume are the same. On ultrasound, what we see is, what I had also practically observed is, once you deflate the cuff, the paratracheal air column width increases. So somewhere in the literature, it was mentioned that if a 16 mm space is there between the tube and the laryngeal, then there are less chances that there is an edema. Especially in robotic surgery and Trendelenburg position or a prolonged surgery, before extubation, we can put a probe and just see. Sir.
Yeah. So that's a very useful potential application. Probably prophylactically, you can put the probe and try to measure and probably predict. Okay.
Yes.
Thank you.
Thank you, sir.
It's a question by Dr. Paliwal. Significance of this, I think, Dr. Anita.
Yes, sir.
Yeah. See, in fact, this is significance of ejection fraction in pregnant patients with eclampsia, preeclampsia group.
Yes. In literature, it is said that if the patient is having very low ejection fraction, then it is important, because in pregnancy, usually there is the term preserved ejection fraction. We can see that also. That is also associated with poor outcome. And patients with PIH, and if not having any cardiac valvular disease pathology, then there is no significance of calculating ejection fraction, I think.
So one difficult one set of difficult cases which we get suddenly, being a tertiary care center, generally you have referred cases in patients with peripartum cardiomyopathy.
Yes, sir.
Cardiomyopathy.
Yes,
So
sir.
that's one real dangerous thing, and we have got mainly systolic failure.
Yes, sir.
Yeah, that's one thing. Probably Dr. Ayyappa also has that in mind.
Yes, it is in literature. It is said that peripartum cardiomyopathy is associated with poor outcome if the ejection fraction is very low. Like if it is less than 25%, then it is definitely the poor outcome in such patients.
Yeah, so that's one we do encounter, and outcomes are definitely poor. So as compared to and in the routine cases, as you say,
Okay.
Preeclampsia, eclampsia group, or chronic hypertension or whatever, they are still able to maintain the cardiac output, go through normal labor also, and have repeat normal deliveries.
Yes.
So that's one which you have to keep in mind. And you are speaking about the AC inhibitors and ARBs.
Yeah.
For the sake of postgraduates again, for the upcoming exams, one of the standard questions the examiners would always ask, especially senior examiners, would be, you did speak about stopping it. You
Yes.
said the immediate previous dose is ideally to be stopped.
Yes, sir.
So is it so uniformly for all the indications?
Sir, there is a dicey feature. Actually, many literature said we can continue. There is no harmful effect of such drugs, but some literature says that it is associated with poor outcome in CABG patients, especially. So there is a lot of literature which is pros and cons of such drugs. So this is not concluded particularly that whether we should stop or we should not stop. So what we can do, we can assess clinically about the patient, that whether we can continue in such patients. If the patient is not having very prone to hypotension perioperatively, we can continue, because it depends on the, I think, uh, the clinician. I think depends on the clinician, because I have gone through multiple articles which are saying that we can continue or we can stop.
Yeah, I think the main fear was the route of action of these AC inhibitors. The vasoconstrictors we use routinely during intraoperative period also act through the same mechanisms, through same route. That is the angiotensin through catecholamines. So they were saying there will be the hypertension will be resistance to will show resistance to the normal management of hypertension with the regular vasoconstrictors used during the intraoperative period. That was
And
the
also,
fear.
continuing ACE inhibitor ARBs in cardiac patient will decrease the incidence of post-op AKI also. So there is the preference of surgeon to might continue.
Okay. So the surgeon, and I think the procedure.
Just for the benefit of
Sir,
Yeah. No,
Yeah,
I
for
think
the benefit of postgraduates, you had described so many risk assessment tools and frailty index, no? Which one they have to remember and which will be more user friendly or more useful in risk assessment of patients with cardiac conditions.
yes, sir. Sir, normally the patients come for non-cardiac surgery, then we go for Lee's RCRI index, that is MACE scoring, major adverse cardiac event scoring. If the patient come for particularly cardiac surgery and we are assessing for cardiac surgery, then we will go through the Euroscore, because it is including all three factors, that surgery related factor, patient related factor, and the uh, demographics. So I think Euroscore is the better. And in the literature, it is said that Euroscore predicts the overall 30 days mortality, which is very beneficial of this scoring rather than all the scorings, because like STS scoring, which is particularly for surgery scoring, but we are not using, surgeons are more using that STS scoring. So being an anesthesiologist, for cardiac surgery we recommend Euroscore, and for non-cardiac surgery we use RCRI.
Probably to supplement, you're talking about investigations also. When we talk about the peripartum cardiomyopathy, there is, as I said, there is greater risk of mortality. BNP assessment would be one which can give an early clue.
Yes, sir.
Probably, yeah. Even in obstetric discussion. So role of BNP has been discussed in an assessment, clear indicated preoperative testing in this set of patients.
Sir, according to recent guidelines, ACC or AHCC guidelines, which says that there is not routinely recommended TROP-I or BNP test. If we are thinking that it will may benefit the patient's outcome, then only we can go through the such test.
Okay. So if we have a sufficient symptomatic indications and functional limitation,
Yes.
as you say, then we can decide. And is there a scope for, of course, the whole battery of tests? Otherwise, you are discussing the CPET test, the cardiopulmonary exercise testing.
CPET tests, sir, not using in cardiac surgery patient, because
Yeah.
they have limitations of performing such exercises. So we are
Yeah.
not routinely doing CPET test.
Yeah. So this is what I just wanted this to be conveyed to the PGs also, because it comes automatically while discussing. So they'll say ECG, echo, or CPET. CPET is there everywhere now, but not to be generally spoken about in this set of patients for cardiac procedures per se. Okay, so one again, a good old question for me before we check for others is about the digoxin. Some of the patients would still be on digoxin, right?
Yes, sir.
Some of the practitioners, cardiologists would advise. So is there a need for continued care in the perioperative period?
Sir, as from literature, digoxin can be continued before surgery actually.
Okay, with the usual riders. Okay,
Issue
about the potassium.
hypokalemia thing should be kept in the middle.
Renal
Okay. I think Dr. Indrani Madam is there. Indrani Hemant Kumar, our GC member. Madam, are you there?
There.
Yes, I think she is there. She has to mute and talk.
So are there any questions from the group? I think they have been exhaustively presented. And in fact, the recording would be very helpful for the practitioners and the PGs to go through once again, understand. And I think I will also share the email IDs with the permission of the speakers. I'll put it up in the YouTube. So if anybody has got some doubts and clarifications, I think they can send messages to you. Right?
Yes,
Bharat,
yes, sir, it's fine with me.
Yeah. Okay, thank you. So no other questions? Okay, thanks, Dr. Bharat Paliwal, Professor AIMS Jodhpur, and Dr. Aarti, Assistant Professor, having spared the time and having prepared nicely the presentation. So, on behalf of the medical college, the VIMS is now called as Ballari Medical College and Research Center, and the Ballari Anesthesia Society. We thank you very much for the presentations and hope we can have your services sometime in the future also.
Yes.
Thank you very much. And thanks to all the participants in today's program. What will we see next time? I think this is 48th month we have done non-stop. Another 2 months. Yes. So thank you once again, Bharat and Aarti. Good night.
Thank you.
Thank you, Srivastava sir, and thank you, Balabhaskar sir, for the opportunity.
Yeah. Happy New Year to everybody.
Happy New Year.
Happy New Year.
All.
Thank you. Thank you. Thank you very much.
Happy New Year.
Thank you very much.
Good night.